is an chalta firta encyclopedia of syndromes, I think, in POSI. And I've always found him very resourceful as far as this syndromes are concerned. So we have our faculty today, Dr. Sangeet Gangadharan, a dear friend, and currently is in UK. And as he told me, he will be soon consultant at Glasgow. So it's a really proud moment for all of us, Sangeet. And he will take us through the syndromes of clinical importance in pediatric orthopedics. Later, Orthokids fellows, they have prepared a few cases which will also delineate the outline. And I will invite Meet to introduce our faculty today, and then we'll start the proceeding. Welcome, Sangeet.
Thank you, Dr. Maulin.
Thank you, sir. So today we have Dr. Sangeet Gangadharan sir with us. Sir has started off with a fellowship in pediatric orthopedics at CMC Vellore, and sir has worked in many reputed hospitals. He worked as senior registrar in Ganga Hospital, Coimbatore. Sir was an international clinical fellow in Alderhay Children's Hospital in England, and as sir just mentioned, he is currently a clinical fellow in Sheffield. So thank you for taking time out for us, sir, and we can start with the sessions.
Yeah, so for all those Indian colleagues, this is about 4 a.m. in UK, and Sangeet was kind to continue with that schedule, to wake up early and not to disturb the Orthokids fellow schedule. So thanks for that also, Sangeet. We had a lecture of Federico, and he woke up at around 3:30 in France. So we are fortunate to have great faculties. So thank you. Sangeet, all yours. You can share your.
Thank you. Thank you, Maulin sir and Maharishi, for the introduction and for giving this opportunity to present this topic, which is quite interesting and can be boring depending on how you look at it. I'll try to make it as interesting as possible, but let me warn you, it is a wide array of X-rays and clinical features, and there are almost 400 skeletal dysplasias. So it may get a bit boring. To be honest, I love doing looking up skeletal dysplasias and working up, but my expertise is very limited. I still approach, I still look into resources, especially the internet and database. I refer to books before coming to any conclusion. I'll share my screen. This presentation, it's not a PowerPoint presentation. It's a different software. I hope it works. Are you able to see the screen?
Yes, sir.
Okay.
It's crazy, no? Sangeet, this is not new to us, this crazy thing. One of my
Crazy,
yeah. One of my fellows, Kaiser, was quite smart on using this. Anyways, it's interesting software.
Yeah, it was kind of new to me a few years ago. It's become quite slow now. So I'm slowly moving away from Prezi. Okay, so I'll be talking on a brief approach to skeletal dysplasias. We definitely cannot cover all of dysplasias because there are almost 400 dysplasias and syndromes. I'll go through the introduction, the terminologies, nosology, and an approach to the diagnosis of skeletal dysplasia, which will give you a rough idea on how to get a ballpark diagnosis and how to work up any child with dysplasia. So in introduction, we look at overview of dysplasia, the terminology is used, and what exactly is skeletal dysplasia. So it's a group of more than 400 complex conditions with extraordinary genetic problems. And this is based on the recent revision of the classification of skeletal dysplasias. The aim of this topic, this lecture, is to familiarize with the terminologies used in skeletal dysplasia, the basic classification system, clinical findings of common skeletal dysplasias, and pathognomonic radiological features, what you look in an X-ray, and how do you work up a child with skeletal dysplasia. So a dysplasia is defined as an abnormal bone structure due to faulty differentiation and organization. So basically, it's a faulty developed bone, which can lead to an abnormal size, shape, form, and function of the skeleton. And it's basically due to a gene defect, which is expressed continuously from intra to extrauterine life. Short stature is defined as any child whose height is 2 standard deviation below the mean for children for the same sex and chronological age. And ideally should be within the same racial or ethnic group. However, we don't have that much database as of now. And this 2 standard deviation will correspond to a height which is below the 3rd centile. Coming to the terminologies. So this is the terminology used for limb dysplasia or limb shortening. Rhizo means root, which if a limb is short from the root, that is the arm segment or the femur segment, it's called as rhizomelia. Mesomelia is the middle segment. Acromelia is the digits, and there can be a combination of these, acrorhizomelia or micromelia or acromesomelia. I'll show you a few examples of these. This one is an example of rhizomelia. Achondroplasia, the picture to the left is a typical clinical picture of achondroplasia. You can see that his arms and femur are short. Another lethal condition with rhizomelia is thanatophoric dysplasia. You can again see the same clinical features here. Mesomelia is wherein the middle segment is short. So either the tibia fibula or the forearm and of the radius and ulna, as seen in Madeleine's deformity or Léry-Weill syndrome. There are a few rare cases of acromelia, asped or angel-shaped phalangeal epiphyseal dysplasia, or June syndrome with short ribs and polydactyly and short digits. Acromesomelia is not a very common disease, but it can be seen in Ellis Van Creveld. I'm sure you must have heard of this terminology wherein you have short ribs, polydactyly, cardiac defects, and Robinow syndrome, which is another type of acromesomelia, wherein the digits and forearm will be short. Now, the recent classification of skeletal dysplasias, they've simplified it into a few subtypes. So it may look vast, but it is quite simple. Bone dysplasias with low bone density, with high bone density or sclerosing bone dysplasias, tumor-like dysplasias, dysplasias involving metaphysis, epiphysis, or the spine, short stature, lethal dysplasias, and storage disorders. So this is the basic classification of skeletal dysplasias. In meta, epi, or spondylodysplasias, there are 3 types. One is wherein the involvement of spine is less. So that could be multiple epiphyseal dysplasia, Stickler, chondrodysplasia. I'm not gonna go through all these names and confuse and bore you. The second type is has more of spinal involvement, and the last one is metaphyseal or spondylo-metaphyseal dysplasias. Short stature can be proportionate or disproportionate. We all know that. Now, in proportionate short stature, you can have a short trunk and a short limb. And whereas in disproportionate, it is usually a normal trunk with short limbs. And these are few of the examples. Lethal dysplasias thanatophoric dysplasia, short rib polydactyly syndromes, campomelic dysplasia, type 2 osteogenesis imperfecta, we all know, is a lethal form of dysplasia. Hypophosphatasia, some types can be lethal, some survive into adulthood. This is a picture of type 2 osteogenesis imperfecta. This is a pathological specimen of a fetus at 13 weeks. And you can see the multiple fractures in the ribs here, and the typical femur, which is not very clear here, but they're called accordion femur, the crushed kind of femur. Storage disorders, mucopolysaccharidosis, there are multiple types in it. Bone dysplasias with decreased bone density, so hypophosphatasia, rickets, pseudoparathyroidism, osteogenesis imperfecta, they are classified into this class. Sclerosing bone dysplasias and tumor-like dysplasias. We must have seen more of these kind of dysplasias like Ollius and diaphyseal achalasia or hereditary multiple osteochondromatosis. How do you approach any child with dysplasia? What are how do you reach to a conclusion of what could be the differential diagnosis? So first we start with history of short stature, whether there was a history of short stature in the family, whether it was diagnosed prenatally or at birth or later during childhood. The short stature should be documented on the height chart. Usually the pediatricians document this. For achondroplasia, you have specific height charts. This is a pseudo-achondroplasia, wherein at birth, the child may appear pretty normal, but as the child grows, the deformities are manifested. You can see the typical short limbs in this child. Antenatal history, you should sometimes parents in their second or third trimester will come to you with a report of short femur or short humeri. If it's less than 5th centile or less 2 standard deviation less in the second trimester, you should suspect skeletal dysplasia. Family history and pedigree should be noted to check the genetic transmission of the dysplasia. Body measures at birth, that is length, weight, and head circumference. Ask for additional history of joint pain, ligament laxity, motor milestones, and growth velocity. This is an autosomal dominant father with achondroplasia. And this is the pedigree which we should be trying. Usually the geneticist makes a pedigree. Prenatal consideration, again, this are usually seen by clinical geneticists or radiologists. Rarely they come to us with reports asking for prognosis. But I believe as an orthopedician, the best way is to direct them back to the clinical geneticist. So prenatal considerations are ultrasound scanning. In India, I believe this is an old slide. It was 16 weeks if there's a positive history when you do an ultrasound scan for anomaly. 18 to 20 weeks is the usual anomaly scan. Just correct me if I'm wrong. In the UK, it is done at around 16 weeks. There's a strong suspicion of dysplasia if the limb measurements are more than 3 standard deviations below the mean, or the head circumference is more than 75th percentile. In lethal dysplasias, they are usually detected earlier in gestation. And these are the characteristic findings. Femoral length is to abdominal circumference ratio will be less than 0.16, and chest is to abdominal circumference ratio will be less than 0.6. Usually these are all, again, recorded by the radiologist. I don't want to go into the details and lose track. Ultrasound, what do they record during ultrasound of an anomaly scan is the degree of bone shortening, distribution of involvement of the limbs, rhizo, meso, or acromelic, bone fragility, if there are fractures, the density of the bone, mineralization, configuration of the skull, size of the thorax, and number of digits. Here are a few examples. Here you can see the foot is short 2.6 centimeter, the figure on the left, whereas on the right side it is a normal size foot. So here the foot is to femur ratio is slightly on the lower side, which indicates a skeletal dysplasia. That's the head of a fetus, and you can see micrognathia. Micrognathia can be seen with call2 gene deficiencies. This is an ultrasound of the skull, and that's typical thanatophoric dysplasia skull, clover leaf type. You can see on X-rays or on ultrasound. The spelling is wrong there. It's campomelic dysplasia, wherein the femur, the humeri will be bowed. It is a kind of lethal dysplasia. Some of them survive into adulthood. Polydactyly and clubfoot. Here you can see the typical findings in osteogenesis imperfecta, stippled ribs and absence of skull ossification and shortened femur. In clinical features, you look at the cognitive impairment. It is most of the skeletal dysplasias, the children have a normal intellectual development, except in DMC. I find it difficult to pronounce. Dwive, Melchior, Clausens. Except for that dysplasia, most of the dysplasias have a normal intellectual development. Hearing and vision should be checked. Vision can be affected in call2 gene deficiencies like spondylo-epiphyseal dysplasias, wherein you can have myopia, retinal detachment. Hearing can be a problem, like in achondroplasia, the children can have ear infections. With craniodiphyseal or craniometaphyseal dysplasias, they can have hearing loss. And so with sclerosing dysplasias. Facial dysmorphism is seen in most of the dysplasias. Bluish sclera is seen with COL1A1, COL1A2 deficiencies, gene problems, and dentition again in dentigerous osteogenesis imperfecta and Ellis Van Creveld, you can see. Hyperlaxity, spine deformity, and limb deformity should be assessed for. Look at the nail, hair, and skin involvement. Anthropometric measurements like height, weight, head circumference, and upper segment, lower segment ratio. So that's the normal upper segment, lower segment ratio for reference. Usually it's 1.7 in the newborn, and after 10 years, it's slightly less than 1. At 10 years, it is 1. So based on the configuration of the skull, these you can derive these differential diagnosis. Now let's look into some typical clinical pictures. So this is achondroplasia. You can see short stature, and this is a disproportionate short stature. If you ignore looking at the limbs of this patient and just look at the trunk and the head, it looks fairly symmetrical, except for the saddle nose. So this is a disproportionate kind of short stature with rhizomelic. You can also call it rhizomesomelic dysplasia. And you can see the lumbar lordosis is exaggerated here. There is frontal bossing, depressed nasal bridge, and the typical trident hand. Achondroplasia is one of the commonest skeletal dysplasias. This is one of the storage disorders, Morqueo's, wherein you can see the typical deformities, sorry, give me a minute to load this. I'm not sure what happened.
No problem. think it's loading, so it may take a few minutes.
Yes, sir.
That's okay.
Yeah. Sorry about this. Let me.
Yeah, you can redo it. No issues.
Are you facing problems with Prezi, or is it just me?
A few of us they used Prezi, but I was not that fancy of it, so I didn't use. But it's very interesting and appealing to start with.
It is, yeah. But I think this is the last time I'm going to use Prezi.
Because sometimes our crowd is not habituated for dynamic screen. They are like one by one, they want the screens. But even in Mac, the screens moving around, the slides moving, that's also very interesting and fascinating.
Oh, okay. The keynote.
The keynote, yeah, that's also
Okay.
good.
Oh.
So if it takes some more time to load, then let it load. Sangeet, and should we start presenting a few cases? By that time, it will
Yeah.
get completely loaded. Is that okay, or
Yeah.
we should wait for some time?
That sounds fine. That's perfect.
Okay, so because by that time your presentation will get loaded and we can start, right? Is that okay?
Yeah, that'll be perfect. Yeah.
Okay. So you might have to stop sharing your screen and meet Goda and Shinam. You can start presenting your case.
Yes, sir.
So Sangeet, you might have to stop sharing your screen. I think, yeah, perfect.
Shall I start, sir?
Yes, please.
Okay, so we have a 2-year-old boy with who presented to us with bilateral knee fixed flexion deformity. So this is how he would mobilize. He could not extend both his knees.
Yeah, so there was flexion deformity, and the child it was obvious that his quadricep mechanism is a problem. He could not stand. And this was a really disabling thing for child with normal birth history and with a good truncal strength. We would always be surprised at why this child is mobilizing this way. Yeah, Meet, go ahead.
So on examination, on examination of the lower limbs, the tone of the muscles were normal. The patella were found to be absent. On the examination of his upper limbs, the nails showed dysplasia. We can see the nails of the thumb are absent. There's the index finger also seems to be dystrophic. and he had a bilateral fixed flexion deformity of the knee. And then, if, as we can see in this picture, the picture on the upper right, there's a gap in the trochlea that's in the patella were found to be absent.
Right. So
And
let's stop here, Meet, and Sangeet, would you comment
Yeah.
on this clinical pictures?
It's, I think the clinical picture says, gives away the diagnosis as soon as he commented on the nails. So
Nails,
nail,
yeah.
nail, yeah, the pic. So yeah, on presentation, then I would say we should have kept the nails apart, separate, and
Yeah.
then put the question.
Yeah,
Yeah,
that's
I
right.
think it's a typical nail-patella syndrome, and um, I think it runs in the family. It's the siblings should be assessed as well. The genetic, because I'm not sure. I'm not very good with genetics. I usually send them to genetic clinical genetics.
Yeah. So Meet, show the family history and further
so
pictures. Yeah.
this is how his family history was. Father had similar complaints. If you can see the nails of the his father's hand, even they appear to be dysmorphic. So
Yeah. Move ahead.
these were his radiographs, and both the patella are found to be absent. The tibia appears to be externally rotated.
Yeah. So in this I think I inherited this MRIs, or probably we got it done. So why, Sangeet, would you like to tell this? What is the clinical picture? Sometimes, we miss the patella is hypoplastic. What other clinical features you would see in nail patella syndrome? What is typical about their gait?
I'm
Sangeet.
not very sure.
Okay, so let me tell you what happens, because either patella is dislocated or absent. Sometimes we see this quadricep mechanism is laterally subluxed, and it goes gradually posterior. So the quadriceps, they act as flexors of knee, and so there is flexion deformity. And what happens is it turns the tibia outwards. So you would see on a typical X-ray AP of femur and kind of oblique or lateral of tibia. And they have very tight iliotibial band also. And some of them have very significant lordotic spine. So they, of course, this child could not walk, but those who could walk, they have very big lordosis and rotational malalignment in the extremity. And if we do not know this thing, then we will miss the patella. So it's always look at the nail, as Sangeet said, and if you find something wrong with nail. So nail patella syndrome is a one syndrome. Which other syndrome you mentioned, Sangeet, where the nail would be problematic, nails?
So I think it's in cartilage hair hypoplasia,
Dysplasia.
but dysplasia, yeah, and
So
it's pycnodysostoses. The fingertips there'll be acro-osteolysis. The distal phalanges will be osteolyzed, but I'm not sure. There won't be brittle nails or anything, but it'll be abnormal shaped and stubby.
Yeah, that's right. So an ultrasound is very important in these patients because you have to track the quadricep mechanism. Even though patella is absent, that doesn't mean that quadricep mechanism is in place. So a good radiologist will tell you that this is shifted laterally, and then you have to deal with like you have to realign the quadricep mechanism, just like a congenital patella dislocation with proximal distal realignment. And I think that's what we did in this case sequentially. Yeah, Meet, go ahead and show.
So
this is wonderful X-ray. So let's Meet. Let me ask other fellows and not Sangeet. Sangeet would know this. Let me see who is with us. Puneet, Raman, Shamal, Vivek. So can someone tell me what is wrong here? What is typical of this X-ray?
Posterior iliac horn is seen, sir.
Vivek, great, yeah. Puneet, very good. So this is an iliac horns is a pathognomonic of Nail-patella syndrome. Of course, we saw this in retrospect, once we diagnosed Nail-patella syndrome. Sangeet, would you like to comment on this X-ray and tell everyone?
I think Puneet has already commented. So usually it's in the ilium that you can see the horn, and I don't think there are any other features you see in the pelvis. You might know better, Dr. Maulin.
Yeah. So you see this sclerotic thing like a horn. I mean, in this patient, as patient is young, we see it very small, but sometimes you see a sclerotic concave thing in the center of ilium, and if you follow it, it's like a horn. So the iliac horns are very pathognomonic of Nail-patella syndrome. Yeah, Meet, go ahead.
Yes. So just going back to literature, this was a paper published in the JPO 2003, and this was a follow-up of 8 patients, 6 of whom were related, 6 of whom were from one family, and this was a 24-year follow-up that they had. They found out that there was the common chromosome that is quite commonly known is the long arm of chromosome 9, and the main complaints that they had were not were patella instability and pain. A few patients from this also presented at a later age, at around 24 or 25 years, and they had arthritic changes. So for this, the authors performed Krogius-Listen procedure, where they what they do is they basically realign the quadriceps mechanism, and this is ideally done at a younger age to avoid early arthritis, which was seen in the late presenters. So that is what we have performed. We performed proximal and distal realignment of the quadriceps mechanism, and as we can see on the image on the right, the extension has been achieved quite well. He can flex to almost nearly normal. And if we just look back at the image, how he was mobilizing, and this is how he could mobilize after the surgery.
So this was what I was mentioning, Sangeet. So see the lordosis.
Yeah.
And this is due to abnormal femoral rotation. These patients have excessive, I would say, external rotation. So they are retroverted femurs. And although they walk with a bit of lordosis, and that gradually improves once we realign this.
Okay.
Yeah, so I was surprised yesterday to see the follow. I did not know that he could not walk, but if we can realign the quadriceps mechanism, some of them, they start independent upright mobilization. So it's a good surgery to do earlier on. Yeah, good. Meet. Thanks.
Yeah, okay. Thank you. And just to finish, so these are the associated systemic anomalies that we should look out for. There's renal involvement. Ophthalmologically, there can be glaucoma or heterochromidia iridis. A trident hand, as is also seen in quite commonly seen in achondroplasia, may also be seen in this. The hip shows coxa valga. Spine may show scoliotic deformities or spondylolisthesis. And horns are commonly seen in the iliac, that's pathognomic, but it may also be seen in the clavicle. It has also been reported in the clavicle. So just to summarize, the tetrad of Nail-patella syndrome is, as the name obviously suggests, there's hypoplastic nails, and patella may be hypoplastic or absent. However, there is also patients may also have radial head dislocation, and they may present with an elbow fixed flexion deformity. And iliac horns, though they are said to be pathognomic, but they may not be seen in all 100% of cases. They are seen in around 70% cases.
So, Meet, what is the cause of these horns? Why it appears? Could you find that?
Sir, I did not find a cause for the.
You should find that out. Why that appears, on clavicles and on the ilium, and not in other conditions. Thank you. So Sangeet, are we ready for your presentation, or we should present another case? You are mute, Sangeet.
Sorry.
Yeah, are you ready for presentation?
No, it's not loading.
Okay.
We can go ahead with the next presentation.
Okay, yeah. So, Goda Siri, Goda, you want to present?
Yes, sir.
Yeah.
So are you able to see the screen?
Yeah, we can.
So Good morning, everyone. I'm going to present a case of skeletal dysplasia in a 4-year-old boy. So we had a 4-year-old boy who has been brought by his parents with complaints of short stature, abnormal gait, and deformity of right lower limb. So these are his clinical pictures. We can see he's apparently short for his age. There are flexion contractures of the elbow and a right-sided genu valgus.
Right. So let us stop here. Go back. And Sangeet, can you tell us, from looking at this clinical pictures, what the differentials would come to your mind?
Yeah. So we have a child with short stature here, and this seems like a proportionate short stature. The trunk seems to be okay. There are deformities and contractures upper limb. So how I work up any child is, first I look at the so we don't have x-rays yet. So what are the associated findings or contractures? Does he have polydactyly or anything?
No, sir. He doesn't have any polydactyly.
So Sangeet, we are not taking exam, but I want you to teach how you take or assess a case so that all the fellows would learn, So take it that way. Yeah. So there is no polydactyly, yeah.
So an approach would be so short stature. You have to see, you have to plot his height and see if it is falling less than third centile before calling it short stature, before labeling it as short stature. Once you know it is short stature, you assess his upper segment to lower segment ratio, and that should be based on him sitting on a chair. That will give you a rough estimate. So if he's sitting on a chair and if his trunk looks of normal height, then you know that the thoracic height or the spinal height is fine, which means spinal involvement is not there. And then you look at the limbs. And once you look at the limbs, like we discussed, diagnose it to be rhizomelic or mesomelic or acromelic based on the shortening. So that's based on the findings. Now, once you know that it is an abnormal stature, you dig into the history and ask the parents if he has always been short, if there's a family history of short stature or any consanguineous marriage, anyone in the family who had early onset osteoarthritis or replacements of the knee or hip, or was wheelchair bound, or any deformity corrections that anyone underwent. So that would be in the history. Ask for prenatal diagnosis if they've picked up anything on the antenatal scan. Was there previous history of abortions or any other history during the antenatal period? Then coming to the clinical workup, do a head-to-toe assessment. Look for his cognition, vision, hearing, facial nerves, and look for the face. The face, to me, it looks almost normal.
Yeah.
There's no hypoplasia or anything. Look at the dentition. Look at the sclera. So that is in the face. Look at the hair. You can have sparse hair in chondrodysplasia punctata. Then you look at the skin, whether there's dryness or any neurocutaneous markers. Look at the the spine if there's kyphosis or scoliosis. And then you go to the limbs. Limbs I've already covered. Look at the digits, the nails, and then you look for
Go ahead, please.
Then you look for associated deformities, or in deformities you have to look for dislocations, contractures, pterygium, these kind of things, and you have to look for the characteristic findings. There are some characteristic signs like trident or a hitchhiker thumb or polydactyly, syndactyly, which will give you a clue to the diagnosis. And once that's done, then you go ahead with the investigations.
Perfect. So like if I summarize, then we first see the height of the child. So all of us should have access to growth charts. Now I have privilege with my wife is endocrinologist, Pedendo. So we have this growth charts. So first you plot them and find out they are really short. They are less than 2/3 centiles. And the second thing you should do is upper segment, lower segment ratio, as Sangeet said. And with a very nice picture or a slide he shared that 10 years this segment is same, and then the lower segment increases, so that we should be aware of. So there are two things. And then you find out which segment is it, the rhizomelic, mesomelic, or what is the segment which is shorter, and then systemic examination, as he said. So Goda, take us through what clinical findings we have, and then we'll discuss the X-ray. Sometimes, I also did, when I find a child dysmorphic, I would see the X-ray, and then looking at the X-ray, going retrospectively, what is that is also one way. And the best thing, as Sangeet said, that always send the child out of your consulting room and look into the literature or OMIM and see the clinical synopsis and try to arrive at clinical diagnosis, and then you add up the investigations. So yes, Godal, now take us through what features we had.
So we had short stature, flexion contractures, and genuvalgum. And this was his gait. So we plotted the growth charts for him, and his height for age was less than 3rd percentile, and his weight for age was at 3rd percentile, and his BMI for age was at less than 50th centile, and his upper segment to lower segment ratio was 1.3:1, which was falling under a proportionate short stature. So we went ahead and we investigated. Scanogram on the right is of a normal 5-year-old, and the scanogram on the left is of this boy. So we can see that the epiphysis is flattened and it is small compared to the one on the right. There's genuvalgum, there is epiphyseal irregularity, there is beaking of the metaphysis, and this classically shows delayed appearance of ossification centers. The one on the right is of a normal child at 5 years of age, and this on the left is of this child. And obviously, we can see delayed appearance of the ossification centers.
Right. So let us stop and can you go back to the slide before? Yeah. So Sangeet, based on this X-ray and the findings Goda explained, can it help us in making some diagnosis?
Yeah, definitely. So when you look at an X-ray for any child with skeletal dysplasia, you may think that this is very pathognomonic of a particular dysplasia, but many a times it is not. So what we need to look at is the way we work up is more important than arriving at a diagnosis. So in bone, what you look for, one is the shape of the bone, the number of the bone, structure, mineralization. So if you look at the shape of the bone, there is a deformity, definitely. And second is an anatomical involvement. So whether it's the epiphysis or the metaphysis or the diaphysis which is involved, here we can see that the capital femoral epiphysis is flattened, and so is the distal femoral and proximal tibial epiphysis. And of course, there is some amount of metaphyseal widening near the knee. And the density of the bone needs to be looked at. Density of the bone seems normal. And are the number of bones normal? So the number of bones is mainly for the hands and feet. You look for syndactyly or polydactyly or absent bones. That's what you look for.
Yeah.
And so here, if based on this X-ray, we know that it is a skeletal dysplasia because there is epiphyseal involvement. So the next step would be a skeletal survey. In a skeletal survey, the typical skeletal survey consists of your skull, AP and lateral views, a hand X-ray, especially the left hand, a PA view, spine X-ray. In spine, we usually go for the thoracolumbar lateral spine X-ray, a chest AP view, a pelvis view with the lumbar spine, again AP, and one upper limb and one lower limb. So this is a typical skeletal survey, so that we don't miss out on anything. So this being epiphyseal involvement, I think this could be one of the types of subtypes of multiple epiphyseal dysplasia. Spine clinically did not seem to be involved. So, but if there's a skeletal survey done, then it will be more helpful.
Yeah, Goda, you can show further X-rays.
Yes, sir. So these were the wrist X-rays. They are showing delayed appearance of ossification centers. And these are the lateral view X-rays of the knee as well as the lateral view of the forearm and elbow. Similarly, here also we can see small flattened. We do not see the epiphysis at all. Widening of the metaphysis is also there, metaphyseal irregularity. Along with epiphyseal involvement, there is overlap of some metaphyseal dysplasia features as well in this case. The spine X-ray, AP and as well as lateral are normal and is normal. There's no involvement of spine in this case. So we've gone through literature and found the case of multiple epiphyseal dysplasia. This was seen in 6 generations of a family with 17 members being affected, and the study was done in 12 living members. Here, mutation in COL9A2 gene was seen, and the clinical features like short stature, limb deformities, joint pain, and all these were like similar to the case which we've seen now. And the radiographic features like delayed ossification center, irregular epiphysis, all this were also similar to the case which we have seen now. So it is most probably a case of multiple epiphyseal dysplasia, but with an overlap of metaphyseal dysplasia characteristics as well. So here we've done growth modulation with medial epiphyseal. This is for the right side, and this is the post-correction radiograph on the right. And he presented to us 1 year, 7 months post-surgery. The right genu-valgum was corrected, but he presented with a deformity on the left side. So this was the pre and this is post. So we went ahead, removed the epiphyseal, the A plate on the right side, and recently operated him for his left-sided deformity. So,
yeah.
Thank you, sir.
So, the few points to note is while you operate, you can do an arthrogram, and
Yes.
an arthrogram will help delineate the epiphyseal margin. So it will make your life easy to put the 8 plates. That's one. And many a times, these deformities are likely to relapse or recur, or the existing physiologic alignment may get exaggerated with time. So you have to explain this to family. Sometimes if they do not have understanding that this would recur, they will blame you that why this happened. So that is, the counseling is very important. And at times, we just remove the metaphyseal part of screw. So if deformity relapse, then you just put the screw in. I tend to remove the implant and put it back because it takes only 6 minutes. It's not a big procedure, but that some people are practicing that. Because sometimes, the deformity happens in the other way. And this patient had some social issues and they could not follow up in time. They came a little later, and now we see that the right limb is going into genu varum. So that's again, you have to explain that timely removal of implants is extremely important. All right. So what other, the limb deformities we can treat now? This boy is also having arthritic. Elbows are flexed. And I hope this does not go into progressive deformity. It's about 30-degree flexed, and you can see irregularity of distal humerus. Have you done anything, Sangeet, besides therapy? Can we do anything else?
So, arthrodiastasis has been tried for multiple epiphyseal dysplasia here. But again, it's controversial, and there's no evidence as to anything needs to be done or not. The second, I would agree with what you've mentioned about the treatment. Arthrogram is usually required because they have a huge cartilage, most of them, and while performing guided growth for these kind of kids with a small epiphysis, one thing how we do it differently compared to the other children with idiopathic genu valgum or varum is we should ensure that the tip of the screw lies in the ossific nucleus rather than just in the cartilage. And yeah, I agree with you that I would remove the whole plate and reapply it. There are reports from Israel, the Pediatric Ortho Association. They noted growth arrest in a few children. I think they have a case series. I'm not sure how many, but they say that the plate can cause some movements and irritation of the perichondrial ring of Lacroix and cause the growth errors. We have seen just one case of growth errors, but theoretically it's possible. So the other thing, the paper which she had shown, it mentions about a genetic defect called COL9A2, but MAD has many subtypes. It can be COL9A2, A1, A3, DTST. So multiple genes can cause, and there are some typical features for particular type of MAD, like MAD 6, 2, and 3 can cause. It has more of knee involvement and less of hip involvement, and this one looks like a type 2 kind of MAD because there is definite lateral condylar hypoplasia and all that. Again, we don't need to go into the subtypes as long as we know what
so then when I send them to geneticists and then they ask for genomic sequence and all, family at times comes back and says, sir, what if would you be able to cure our child, if we have genetic diagnosis?
That's true.
But I say that you should get a diagnosis so that you don't get investigated every now and then. You reach to another doctor and they'll prescribe. So you will save money there. And we know the genetic implications of this, but at times the families, they are not, you have to educate them. So nicely presented, Goda. You should have placed this arthrogram image. That would have been very interesting. So Shyam, do you have your third case? Shyam, I have actually a bunch of cases, quick, rapid fire. So you'll enjoy it, Sangeet, and you can.
Okay.
Shyam, would you like to share your screen?
Yes, I am sharing.
Shyam is in Haldwani currently.
Good morning, everyone.
Yeah,
this is case 1. Patient, 5-year-old male child presented to us with this deformity.
Shyam, we could not see the full screen. I think
with the goal of improving gait pattern, he's having. We can see.
Shyam, we cannot. Can you? Yeah. Now we can see. Yeah. Now go ahead.
Okay.
Yeah. Please go ahead.
We can see he's having a genu-valgum deformity and thoracolumbar kyphosis was there, and he underwent cochlear implant at age of 2 years.
Yeah, so let us stop and ask Sangeet. Sangeet, what this
We
clinical
can see here he was having metaphyseal irradities, humerus, distal humerus, and proximal femur severa with increased ax angle and decreased neck shadow.
I think there is a delay in appearance of digital milestones, probably.
That's true. Yeah.
Anyways, Shinam, please stop there. We are here with all like clinical pictures. Shinam, Sangeet, can you tell us about these clinical pictures? And
Yeah. So, sorry, I missed. What age is it?
I think 2 years or 3 years. Yeah.
2 or 3 year old. Okay. So we have a 3-year-old with short stature and deformities.
Yes, my neck is on.
Okay. I think there's a small, slight lag in your audio, Sheena. So we have a 3-year-old with short stature. I'm sure you've plotted the height for this kid, and then you have come to the conclusion. And he's got, I would say, a disproportionate short stature. If you look at the spine, its spine is slightly short compared to the rest of the body. The upper limbs, I would say, yeah, there is mild rhizomelia, but it's not reflected in the lower limb, so I would not call it rhizomelic shortening. But predominantly, the spine is affected, and there is kyphosis in the spine. And Shinam has mentioned that he had a cochlear implant, if I'm not wrong. So possibly it could be sensory neural hearing loss, which is usually seen with storage disorder. So I'll be thinking in terms of storage disorder. I mean, I may be completely wrong here, but I see that.
So that's right, and I wanted to bring that point that we sometimes see rhizomelic involvement in upper segment, upper extremities, and in not in lower extremities. And as you can see, the genu-valgum deformity, which is most conspicuous to us orthopedic surgeon, kind of want to do growth modulation every day. But we should check this child with clothes off, and you can see the spine and the cochlear implant, as you say, that hearing loss is a part of this syndrome. So Shinam, let's move ahead and show the X-rays, and let's find Sangeet's opinion on that. Shinam, can you advance? Oh, this is such a lovely presentation. Yes. Okay, very good. So on the right side, I think is an earlier X-ray when the child was young. And these are the X-rays which we got now. There is coxa vara and pseudoarthrosis on the right side, you can see. And these are the not very good quality X-ray because we inherited them. Shinam, do we have lateral view of spine? So technology has reached us today.
Yeah.
Earlier on, I used to ask all the fellows to send presentations to me. So if they cannot run, I can run. Shinam, can you advance a slide?
Yes, sir.
Okay. Yes, let us go ahead further. So there is epiphyseal irregularity.
Can you see?
Yeah, yes, move through the cases. Move. We
Okay.
saw this slide. There was a bit of delay. Yes, stop there.
Okay.
Okay, so
Can
this
you
is
see this? Can you see this slide? Case
Yeah.
number. Okay.
So what was the diagnosis in last case? There was spine involvement, genu valgum,
Spondylo-metaphyseal dysplasia.
dysplasia. Yeah, that's right.
Yes. I was confused between it may be Kozlowski type or Morque's. Can you, sir, please guide us to differentiate both on the basis of clinical presentation?
Yeah, can you go back to the X-ray? I can. It'll be easier for me to
Yeah.
explain.
Yes, sir.
Yeah. So in when it comes to Morque's, you can see that typical beaking with any MPS. You can see beaking. With Morque's, it is usually in the center. The beaking is central, and with hurlers, it is more inferior kind of beaking. And the other way to differentiate is to get a hand X-ray. In hand X-ray in Morque's, you can see over-modeled boards, so they'll be more shapely, and there'll be proximal pointing of the metacarpals in Morque's.
So one thing which we all the fellows should remember, and I have learned it hard way, that the Morque's or achondroplasia, they can have atlantoaxial instability. And in one of the patients where I took the child for a genu valgum correction, post-operatively child had paraplegia. And the reason we could not identify atlantoaxial instability, and while shifting the patient, there was sudden flexion jerk, and the patient, my anesthetist required to ventilate the child throughout the surgery because the diaphragm was paralyzed, and he woke up with paraplegia, and we had to give Solu-Medrol. And one point it happened so that child might need ventilator, but fortunately child improved. So a message for everyone is, whenever you are dealing with a Morque's syndrome or achondroplasia, so atlantoaxial instability should be checked. If your child, some of them have basilar invagination, so shift them with a cervical collar. Inform your anesthetist that they have to be careful. Any sudden flexion jerk can lead to cord compression. So I inquired this with the symposium in POSI, and people abroad like William Mackenzie and the faculty from Korea, they do neuromonitoring during even limb deformity correction. So if you don't have neuromonitoring, then you get the spine checked by neurosurgeon that there is no instability, and always keep a collar so that there is no abnormal movement during your surgery, So that's very devastating complication I have faced in my life. So I learned it very hard way. So surgeries are not difficult, but the stress management or taking help of all the concerned people is very important. Surgeries are very easy, osteotomies and growth modulation, but the complication can be devastating. Yeah, so we were very careful in correcting this child, and we corrected simultaneously genu valgum and coxa-vara. We did bilateral osteotomies. Yeah, let's go to the next case, Shinam.
Yes. Can you see the screen?
Yeah, we can see.
Yes. Here we can see there is a short trunk, probably rhizomelic stature. A hand reaches up to greater trochanter, which should be normally till middle of thigh. There is genu vera. There is no trident hand, which differentiate it from achondroplasia. as
Yes.
it mimics achondroplasia features. This is the X-ray of the lower extremity. We can see here genu varum deformity, and the most diagnostic feature, that is lower end of fibula, is long, that differentiated from the achondroplasia, where we have long upper end of fibula.
So, Shinam, can you go back to the X-ray?
Yeah.
Yeah. So we are like we have always been say the beginning of metaphyseal and is a healed we would see a healed rickets like this. Of course, we have some growth arrest lines there. Someone would say this beaking, so it can be blounced. But what is most important is you have to check the height of the child for the age. We see short stature in rickets also, but they are within in the lower range of standard deviations, and these children will be very short. So, Sangeet, please take us again through the clinical and X-ray pictures, and Shinam have very nicely mentioned, but
yeah, sure. Shyam, can you show the clinical picture, please?
Yeah.
So, if you clinical picture, it shows a broad head, a bigger head. The thorax, the chest looks almost normal, and the upper segment of both both the limbs are short. So maybe I would call it a rhizomelic shortening, or a rhizomesomelic shortening. There is no trident hand. There is no exaggerated lordosis, which you normally expect with achondroplasia, and genu varum, both sides. He definitely has a wide metaphyseal, like Maulin Sir mentioned. It should be a differential for metabolic bone disorders as well. If you look at his wrist, they are kind of wide. So you should look at the physis and see if it's healing rickets or not. But there are no other findings on the chest, like Harrison sulcus, or you cannot see the rachitic rosary there. There is depressed, in the facial features, I forgot to mention that the nose seems to be depressed, but it's difficult to comment on without a lateral view. Did he have any lordosis or anything of that sort?
not much.
Doesn't seem to be.
Yeah.
Okay.
So let's go on the X-ray, Shinam, and what can be the likely diagnosis here, Sangeet?
It could be pseudoachondroplasia or hypochondroplasia.
Yeah, hypochondroplasia. Yeah, Shinam, go ahead. And so this was hypochondroplasia, Sangeet, and then I think we did what surgeries we did, Shinam? Growth modulation?
Sir, osteotomy was done.
Okay, fine. Yeah, just move ahead with this case.
Yes, we can see here the same features. There is rhizomelic dwarfism. Hand reaches up to the greater trochanter, not up to the middle thigh. There is knock knees.
You have another picture to show that?
No, sir.
Okay, no problem. Let's show the skull X-ray.
There is calcification of the skull base and calvaria. There is coxavera deformity, and there is metaphyseal irregularities, which are distinguishable. There is distal tibia metaphysis irregularities and proximal distal femur as well.
So, Sangeet, how we should differentiate this X-ray from metabolic bone disease? So, I mean, someone would easily comment it as rickets,
Yeah, that's true. So the diagnosis here, is it achondroplasia or hypochondroplasia? I can then go ahead.
Okay. So, Shinam, what is the diagnosis?
It was
Metaphyseal.
Morque's. No,
But-
it was Morque's disease.
Oh no, the hip doesn't look. I mean, the pelvis doesn't look like Morque's.
Metaphyseal, maybe.
This is
Metaphyseal
metaphyseal chondral dysplasia, if I remember rightly.
It looks like that, yeah.
So
Yeah.
you can see some irregularities in the metaphyseal in the center also, you know. Show the spine X-ray.
Yes.
So of course this T12 looks a bit anterior beaking, but not too much. Either it is just developing Morque's. In very early Morque's, you cannot have all the skeletal findings, but this looks more like metaphyseal chondral dysplasia.
I agree, yeah. It looks like the corner fracture type. If you look at the
Go
ABV
back
of
to the
other.
limb X-ray, Shinam.
Yes.
Yeah, this is like corner fractures. Yes, agree. So corner fractures kind of picture in North America, you have to inform this social services for battered baby syndrome. But here you can see there is irregularity in the center, which we usually don't see in rickets. It's all peripheral most of the times, and beaking and all those features. Fine. So let's move ahead in your presentation. Do we have anything else?
No, sir. I have a question.
Yeah.
Sir, can we differentiate simple, that is Kozlowski type of spondylo-metaphyseal dysplasia from Morque's on the basis of skull X-ray? Is there any differentiating feature between the two?
Sangeet, do you have an answer? I don't have.
Based on skull X-ray, I think a
Yes,
skeletal
sir.
survey would differentiate. In Morque's, what you can see on the skull X-ray is a typical J-shaped sella turcica. So here, I'm not sure. Can you see the pointer? No, I don't think you'll be able to see the pointer. So can you see the sella turcica here, the pit? So that's J-shaped, but again, it is very differentiated. It's very difficult to appreciate that. In many normal X-rays also, I've seen J-shaped sella turcica. So just based on skull X-ray, it is different. It may be difficult. At my level, I cannot differentiate. I would require a skeletal survey.
See, it's important to differentiate Morque's from other metaphyseal chondral dysplasia because in Gujarat, and we published this paper, we have a specific genetic predilection to have a Morque's particular type, and we have international funding for gene therapy for particular type of Morque's. And there is a genetic center here who have got an international grant. So we refer all the patients and they do genetic workup. And some of those patients are on this hormone replacement therapy for Morque's. So that's how we have to differentiate. And those patients can be helped with gene therapy. And by and large, again, it is important to forecast that what would be the adult height of this child, what can happen to the subsequent sibling, what is the chance that this subsequent sibling can also have this syndrome. And many syndromes, we know what systemic problems they can have. So before taking them for intervention, we have to get them screened with a pediatrician who has interest into these syndromes, because they will find out different. So we should find out all the abnormalities before surgery and not after the surgery. That's what I've learned. And to do the risk management, we always get them screened with a pediatrician who will also have a look at them post-operatively. And at times the surgery, as I mentioned, surgeries are not difficult, but complications can be grave. So don't jump for surgery, always screen them, always assess them, and then go for the management. So I think, Sangeet, what you can do is, if you have a simple PowerPoint presentation about syndromes, you can share the PDF to us. And
okay, I have the PDF. I have the PDF. I'll share the PDF
yeah, so I
on the
can,
group.
so we can share it in our this fellows group. Are you part of this fellows group? No, fellows academic group.
No. I can forward it to you.
Yeah. So what I'll also do, since you are in a teaching post, I will add you to that group, and you can also add your fellows there. Well, we have every weekly this training teaching module. They can participate and they can also be benefited. We have different speakers.
Okay.
Right. So it was nice learning a few things from you, Sangeet. It was wonderful. These syndromes are always fascinating and what I shared is what I've learned through my ignorance. And all the fellows, you have done great job of presenting these cases in an interesting way. So thank you very much, Sangeet, for your time, and I hope you have a couple of hours to go to bed before you join your work, or you might like to go to the gym.
No, I'm gonna go to sleep, I think. Sorry about the presentation, and I think I've learned more from this, because when it comes to dysplasia, every day is school day, and I totally agree with you here. A few things we do differently is, since healthcare is free, we refer most of them to the geneticist, and we have a thorough workup and the diagnosis in hand before we go ahead with deformity correction, growth modulation. So most of the dysplasia, since they have a skeletal survey, they do a flexion extension view. That's what the spine surgeons, the pediatric spine surgeons, they always recommend. If you have a dysplasia, a cervical flexion extension view, and they fuse the cervical spine and then give it to us if there's anything of that sort.
So here, I mean, now I've learned to send them to pediatric neurosurgeon and check everything. They also do dynamic MRI, and and then we ask them to fuse it if there's unstable. But some of them, they are not that unstable, but they can get complicated. So it's a rule now that a soft cervical collar while patient is being shifted, and the anesthetic is very careful in intubating and all. Yeah, but as we have this pediatric endocrine, my wife is pediatric endocrinologist. They receive a lot of patients for short stature, and on X-rays they would find that there are some syndromes, and then those patients would be referred to me. And at times I'm also clueless at what is going on, but so that's why we come across many syndromes. So they primarily have been referred to endocrine team, and then they find it's not it's a constitutional short stature or growth hormone deficiency. There's the skeletal dysplasia which is making them short. So that's why we have those patients coming to us. So thanks everyone who joined and spent your time. I hope you learned a few things as I did. Have a good day, Sangeet. Are you coming to Posse?
No, not this year.
No. Maybe in a couple of years we will be an international faculty, as we have other. Right on. So nice talking to you. Meet might get in touch with you, and if he's interested in this deformities, I recommend Sheffield for that deformity learning. Dr. Goda, Goda has already done a few deformity fellowships, so I'm learning from all my fellows now, frames and deformity correction. So yeah, that's right. Okay,
that's nice.
See you. Take care.
Thank you, Maulin sir. Thanks. Bye.
Thank you. Bye-bye. I'm ending the meeting for now.